Have you ever been told you're just sensitive or extra moody? Every month, like clockwork, the week or two before your period brings something else with it. Irritability that feels out of proportion to what's actually happening, a hopelessness that descends without warning, anxiety that seems to come from nowhere, crying at things that wouldn't normally bother you, or feeling like a completely different version of yourself, someone you don't recognize and don't particularly like. You snap at people you love, you pull away from friends, you feel overwhelmed in a way that doesn't match your actual circumstances. And sometimes there's a creeping dread, a sense that things will never get better, that feels in that moment absolutely convincing. And then your period starts, and within a few days, all that darkness lifts. The dread dissolves, the irritability quiets, you feel like yourself again. And then you spend the next 2 weeks wondering whether that last week was real, whether you overreacted, whether something is fundamentally wrong with you. Here's what I want to tell you. That pattern has a name. The clockwork is real. It is not a character flaw. It is not you being too emotional or too sensitive. It could be a recognized, diagnosable, and highly treatable condition, and far too many women spend years suffering through it without ever knowing it has a name. Today we're talking about PMDD, Premenstrual Dysphoric Disorder. What it is, how it's different from regular PMS, what's happening in your brain, and most importantly, what can be done about it. I'm Dr. Susan Zink, a board-certified adult psychiatrist and women's hormonal mental health specialist, including PMDD. Let's start with the distinction most people are fuzzy on. PMS and PMDD share a lot of the same symptoms. The biggest difference is severity and the degree to which those symptoms interfere with your life. PMS, or premenstrual syndrome, affects approximately 75% of women at some point in their reproductive lives. Bloating, cramping, breast tenderness, mood changes, fatigue, irritability, these are real. They can be uncomfortable, and they're a relatively normal hormonal response for a significant portion of the population. PMDD is different. PMDD affects only about 3 to 6% of women, and for those women, the premenstrual phase is not just uncomfortable, it is disabling. Relationships might be strained, work performance can suffer, daily functioning is impaired. The emotional symptoms, the severity of the depression, anxiety, or even rage are in a different category entirely from ordinary PMS. Now, I'm not minimizing PMS. PMS can feel rough, but PMDD can make you feel almost like an entirely different person. And that distinction matters clinically, and it matters for treatment. One important distinguishing feature: if you have PMDD, you should have a symptom-free window in the week after your period starts. That week or two of feeling normal or even good is actually part of the diagnostic picture. If your low mood or irritability are constant throughout the month with a premenstrual worsening but no real relief after your period, that might be more of a premenstrual exacerbation of some underlying condition, although you can have PMDD and another psychiatric condition like major depressive disorder. The distinction matters, though, because the treatment approach differs. So what does PMDD actually look like? PMDD can look like a lot of different things. The word dysphoria means sadness, but PMDD doesn't always look just like sadness. So what mood symptoms do we see? Commonly, we see really severe irritability or anger, often the dominant symptom and the one most likely to damage relationships. Depression, hopelessness, a sense that things will never improve can be a part of it, but also anxiety or a feeling of being on edge that won't settle. There's often a lot of emotional lability, mood swings that feel extreme and hard to control, or a feeling of being overwhelmed or out of control. In severe cases, women can have suicidal thoughts, which usually resolve once menstruation begins. Studies show that up to 15% of women with PMDD can have suicidal thoughts only during the window before the period starts. Other symptoms can include a loss of interest in activities and relationships that usually matter to you, difficulty concentrating, fatigue and low energy, sleep changes, either trouble falling asleep or staying asleep, or sometimes sleeping too much, appetite changes like cravings, overeating, or a loss of appetite, a desire to withdraw from people, And then importantly, there are also physical symptoms like bloating or breast tenderness, joint or muscle pain, or headaches. To meet the clinical criteria for PMDD, you need at least 5 of these symptoms present in most cycles over the past year, with at least one of those 5 being a mood symptom: depressed mood, anxiety, irritability, or emotional volatility. And critically, those symptoms need to begin to improve once your period starts and be minimal in the week after. So let's talk about what's actually happening in your brain. Why does this happen? What is the brain actually doing during the luteal phase that produces this experience? The short answer is that PMDD is not caused by abnormal hormone levels. Women with PMDD don't necessarily have more estrogen or progesterone than women without it. What is different is the brain's sensitivity to the normal hormonal fluctuations of the menstrual cycle. So here's the sequence. After ovulation, you enter the luteal phase, the 2 weeks before your period. During this time, progesterone and estrogen both rise. For most women, this rise is unremarkable. But for women with PMDD, the brain registers this hormonal shift and responds with significant changes in mood-regulating neurotransmitters. As hormone levels begin to fall in the days before menstruation, symptoms escalate. Then, once the period begins and hormone levels drop to their lowest point, the symptoms resolve. The brain has recalibrated, and this is why the relief that comes with your period isn't imaginary, it's neurochemical. Progesterone is particularly relevant here. Progesterone and its metabolites like allopregnanolone act on GABA receptors in the brain. These are the same receptors that anti-anxiety medications target. For most women, rising progesterone during the luteal phase has a mild calming effect. But in women with PMDD, this system appears to be dysregulated in a way that produces the opposite: anxiety, irritability, and mood instability rather than calm. This is something important to keep in mind as you head toward midlife, and I talk more about this in other videos. The important thing to remember is that this is not a character flaw. This is a brain that is wired to respond to normal hormonal fluctuations with an amplified neurochemical signal. Your brain is differently sensitive, and that difference is treatable. It's also worth noting that a history of major depression increases the risk of PMDD, and PMDD itself is a risk factor for postpartum depression and also mood problems in midlife as more hormonal fluctuations occur. These conditions are part of the same spectrum of hormonal mood sensitivity, which is why reproductive psychiatric care looks at the full picture across a woman's life. One of the most important steps in diagnosing PMDD is tracking symptoms prospectively, meaning you record them as they happen over at least 2 full menstrual cycles, rather than trying to recall them retrospectively. This matters because looking back, it can be hard to separate the luteal phase symptoms from the rest of life's noise. Tracking in real time lets you see the pattern clearly, and it gives your doctor objective data to work with. A well-validated tool called the Daily Record of Severity of Problems, or DRSP, is specifically designed for this. It's a daily symptom rating scale that maps your experience to your cycle. And there are also many cycle tracking apps available that can serve a similar purpose if you use them consistently and include mood and symptom tracking, not just cycle dates. These tools can be helpful, although you can also just track on a piece of paper or a note on your phone if you prefer. If you suspect PMDD, I would encourage you to start tracking before your next appointment. 2 months of consistent daily data tells us a lot. So here's the good news, and I want to be clear that this is genuinely good news, is that PMDD is highly treatable. There is strong evidence behind several different treatment approaches, and most women can experience significant relief. The first-line treatment for PMDD is SSRIs, or selective serotonin reuptake inhibitors. This is the treatment with the most evidence behind it for PMDD, and it's the same class of antidepressants that we use for depression and anxiety and other illnesses. But here's something that surprises most people. SSRIs work differently for PMDD than they do for depression. For depression, SSRIs typically take 8 to 12 weeks to reach their full effect, but for PMDD, they can work within the first few days of starting them. And this probably has to do with how SSRIs affect allopregnanolone, that progesterone metabolite we talked about earlier. This means that one highly effective approach is intermittent dosing, taking an SSRI only during the 2-week luteal phase, those 2 weeks before your period starts, rather than every day. Research has shown that intermittent and continuous dosing are roughly equally effective for the mood symptoms of PMDD, but it is a treatment option to do just intermittent dosing. This is significant for a lot of women who are reluctant to take a daily medication but would be open to a targeted approach, and it's a real option worth discussing. Response rates for SSRIs and PMDD are high, somewhere in the range of 50 to 90%. And if one SSRI doesn't work well, switching to a different one is a reasonable next step. What else can we do? Because PMDD is driven by the hormonal fluctuations of the menstrual cycle, approaches that suppress or stabilize those fluctuations can be effective. Oral contraceptive pills, specifically often those ones containing drospirenone, which is a specific type of progestin, have some evidence for PMDD, although the data is more mixed than for SSRIs. And for severe treatment-resistant PMDD, RH agonists, medications that temporarily suppress ovarian function, can be used, although these are reserved for the most severe cases given the side effect profile. Surgical options also exist at the very far end of the severity spectrum, but are rarely indicated. There are also some supplements that have evidence to be helpful for PMDD. The one with probably the most evidence is calcium, taken 1,200 milligrams daily and usually divided into 2 daily doses of 600 milligrams twice a day. There's meaningful evidence that this can reduce the physical and mood symptoms of PMS and PMDD. Also, vitamin B6 at 50 to 100 milligrams daily has some supporting evidence, and studies suggest it works better when it's combined with calcium. Just a note, you don't want to take more than 100 milligrams of vitamin B6 daily because this can increase your risk for neuropathy. Magnesium, vitamin D, and vitamin E also have studies with modest findings. There's a botanical called chasteberry, also known as Vitex agnus castus, and this has some reasonable evidence for premenstrual symptoms and is worth discussing if you're interested in non-pharmaceutical approaches, or if you're interested in adding something to your prescription medicine. Psychotherapy can also be helpful for PMDD. Cognitive behavioral therapy has evidence for PMDD, primarily by helping women manage the distress that comes with the premenstrual phase and develop coping strategies for the most difficult days of the cycle. It's not as powerful as SSRIs for PMDD specifically, but it can be a helpful part of the picture. And then, of course, let's talk about other symptom relief. NSAIDs like ibuprofen can help with the physical symptoms, pain, cramping, headaches. Diuretics are sometimes used to address bloating. These don't treat the underlying disorder, but they can make the luteal phase more manageable while other treatments are taking effect. If you recognized yourself in any of what I described, the clockwork of it, the way it descends and then lifts, the version of yourself you don't recognize, I want you to hear this clearly. You do not have to keep managing this alone. PMDD is not a personality problem. It is a recognized condition with a well-understood biological basis and highly effective treatment options. Many women experience profound relief. The first step is naming it, and the second is finding a knowledgeable doctor who takes it seriously. Next week, I'm talking about anxiety and panic during pregnancy, what it looks like, what's driving it hormonally, and what treatment options are safe and effective during this particular time. If you're pregnant or planning to be, that one is important. Subscribe so you don't miss it, and leave a comment if this video resonated. I read them. If you're in New Jersey, Florida, or Texas, my practice information is in the description below. I would be honored to help you. And please, if you are having thoughts of harming yourself or suicidal thoughts, please call or text 988, the National Suicide and Crisis Lifeline, or go to your nearest emergency room. Help is available and you matter.